Yeah, the background of the study is quite easy to tell because we have several entities who are treated currently with neoadjuvant treatment. Example given, gastric cancer. We have established in Germany and worldwide the FLOT4 regimen for gastric cancer for the peri-operative regimen. And currently we see today in the plenary session the example given Matterhorn data combining neoadjuvant treatment with IO treatment. And this, I think, is a strong rationale to combine therapy directly before initiating surgery, because a lot of patients are not fit enough after surgery to receive an adjuvant treatment. And this, all the patients in the adjuvant trials are filtered by the surgeons, example given. If you have a good surgery, if you have no complications, you are fit enough to receive an adjuvant treatment. If you are not fit enough, you can't have an adjuvant treatment. And this is what we have shown in the GAIN trial, that the neoadjuvant treatment is better than the adjuvant treatment, because the patients directly receive the treatment on the one hand, and they are able to have a full dose preoperatively on the one hand, and this is also the fact that the patients have the possibility to have a PCR or a CR responding on the chemotherapy and not disseminating tumor cells intra-abdominally. All these complications are milder if you administer a chemotherapy upfront, right before surgery. The methodology was, it was a randomized open-label one-to-one fashion phase 3 trial with randomization of GemCis as a standard of care in the palliative setting in gallbladder or BTC, biliary tract cancer, and it was a randomized study one-to-one between peri-operative treatment, neoadjuvant GemCis, followed by radical surgery, then followed by another 3 cycles of GemCis, randomized versus the pure adjuvant or pure radical surgery plus minus adjuvant treatment if the patient was fit enough for adjuvant treatment. And the outcome was that we nearly doubled the overall survival rate and the event-free survival rate due to the neoadjuvant treatment compared to the adjuvant setting, because on the one hand, a lot of patients were after surgery not fit enough to receive an adjuvant treatment, and also in Germany, some centers are not convinced of the adjuvant treatment, and therefore a lot of patients did not receive an adjuvant treatment. Nevertheless, the trial was due to the slow accrual, was stopped early. Nevertheless, the trial was significant regarding the event-free survival, regarding the overall survival. Yes. The clinical impact is currently, due to the smaller sample size, is more or less signal generating on the one hand. On the other hand, otherwise, the trial is positive regarding the statistics. So surgeons are able to think and to administer a neoadjuvant treatment based on this data. According to the NCCN guidelines, it's also possible to administer a neoadjuvant treatment, but nevertheless, the neoadjuvant treatment proposed in the NCCN guidelines is based on only 4 retrospective studies. Now we have a randomized trial supporting the neoadjuvant treatment for the patients, and I think this is the most important fact, that we have now randomized data for the patients. Yes, I think the next step should be a new neoadjuvant trial combined with the IO therapy as immunotherapy for the patients. But nevertheless, also always keep in mind to give the systemic therapy as early as you can.